Hi, and welcome to the lecture on education, socioeconomic status, and health. My name is Maria Glymour, and I'll talk to you today about education in the context of socioeconomic status, provide some evidence on educational inequalities and health, and we'll return to the question about the evidence on educational inequalities and health in the section on observational evidence and research designs. And we'll also talk about measuring socioeconomic status with an emphasis on education. So let's start off by talking about education in the context of socioeconomic status. The motivation here is really around thinking about Lincoln Phelan's fundamental causes of disease framework. Lincoln Phelan, in a really influential set of work in the 90s, proposed this idea of fundamental causes to explain why socioeconomic inequalities in health persisted even as the major causes of disease and ill health changed over time. And this is a quote from one of their papers: "The essential feature of a fundamental social causes is that they involve access to resources that can be used to avoid risks or to minimize the consequences of disease once it occurs. We define resources broadly to include money, knowledge, power, prestige, and social support and social networks. Variables like socioeconomic status, social networks, and stigmatization are included in this concept of fundamental causes." Today we're going to concentrate on the ideas of specifically socioeconomic status, notwithstanding the importance of social networks and stigmatization as in roles of causing disease. I want to emphasize that the idea here is that these are resources that can be deployed in many different contexts to help protect individuals from disease. And it's not just protecting from the incidence or development of a disease, but also remediating and reducing the adverse consequences of disease once it has developed. So you can have a disease and maintain still very good high quality of life under certain circumstances. And these are resources that would help you either prevent disease or reduce the consequences. This is very related to the concept of socioeconomic position or social position, which Krieger has defined as an aggregate concept including both resource-based and prestige-based measures and linked to both childhood and adult social class position. And what I want to emphasize here is the point that this is both childhood and adulthood. It is throughout the life that socioeconomic status and socioeconomic resources really influence health. So the big three dimensions of socioeconomic status, the most commonly measured dimensions of socioeconomic status are education, income, and occupation. And in addition to these, I want to add consideration of wealth and employment status as an employed versus non-employed. So education can include both formal schooling, and it's typically measured as formal schooling, for example, years of completed schooling, including credentials, the number of, for example, degrees that one achieves. But it can also include educational experiences that were outside the formal schooling structure. Income includes both income from earnings, and earning income from other sources, for example, lottery winnings, social insurance payouts, transfers. And occupation is a very important form of socioeconomic, dimension of socioeconomic status, but we can think about occupation as mattering both for the social class that is associated with each occupation, but also the prestige associated with occupations and the actual context and environment associated with each occupation. Typically we distinguish, for example, between manual work, non-manual work, white-collar labor, blue-collar labor, but there are literally many different ways to measure occupation. We'll talk a little bit more detail. I want to contrast income and wealth specifically because they are both measures of financial resources. And financial resources, money can be deployed in all kinds of ways to protect one's health, but it's important to distinguish between these two domains that that are not perfectly correlated, as we saw in the Braveman article, and we will return to this in a bit. And they connote really very different constructs. So as I said before, income includes earnings, transfers, welfare payments. Wealth includes both what one has saved from income across the life course, but also anything you receive from an inheritance. It's essentially assets minus debts. And these two things may be very different at different life course periods. So for example, in old age, people are less likely to have ongoing income, potentially ongoing income, and they may be living off of wealth. And even if they don't have any income, they may still be able to have plenty of money to deploy to protect their health. On the other hand, some people can have no wealth, but essentially have an ongoing income that is sufficient to protect themselves from adverse health events. So these are, both dimensions are actually quite important, and they are potentially important for more relevant at different life course periods and different ages and different populations. I also want to distinguish between occupation, by which we mean what do you do in the paid labor force, what is your job, versus employment status, being employed versus not employed. And one might be employed, i.e. in the paid labor force, but also one might not be employed because you are working but not for pay, for example, working at home, providing household labor that's not reimbursed, you're disabled, or you're retired, you've intentionally left the paid labor force. Or seeking employment, but you have not been able to find employment. So these are, in fact, very important distinct dimensions of SES. So let's think about education and why education could be such an important resource, why education might matter for disease onset, progression, or consequences. Now, I want to emphasize all three of these: disease onset, progression, and the consequences of disease. And I want to stop here and ask everyone to just stop the lecture and think for a moment about a specific health outcome, whether that outcome is a disease, development of a disease, the progression of a disease, or the consequences of the disease. So think about a specific health outcome and write down possible mechanisms via which education might influence this health outcome. So I'll just stop the lecture for a few seconds while you can do that. Okay, so let's talk about some potential mechanisms. The first thing that education affects is a whole host of social variables. So we know that education influences your ability to obtain employment and the particular context of employment that you do obtain. So, for example, it improves your ability to get a job and to get a high status job and a job with high earnings. So education influences your employment and your income. If you have more education, it may actually mean that you earn more in the same job. We think that your income also influences your wealth via savings, so education therefore influences your wealth. Education also affects things that are not quite as obviously linked, sort of non-financial consequences. There are many non-financial consequences of education. For one thing, and it's very important to understand, education influences, because education and formal schooling takes up so much time and it puts children together, it really influences the social relationships and the social networks that people form. It influences sometimes who your closest friends are, who you can call on for help in need, potentially who you marry. These are all social networks, and the social network relationships that you form mean that you have access to resources, including knowledge and information, and potentially financial resources and advice and emotional support from that network of people. So education is very important for forming the social network. Of course, education conveys knowledge, and that knowledge may actually be valuable with respect to health in and of itself. Education also conveys not just knowledge or factual information about any particular situation, but it teaches you skills, and those skills may be very, very flexibly deployed in many different situations to protect your health. Those skills are things like literacy and numeracy, your ability to actually use information to help protect your health. And some sort of psychological habits like self-efficacy, sort of soft skills are also influenced by education. And at this point, we actually don't know for the overall effects of education on most health outcomes, we don't know which of these mechanisms are most important. That's a really important area of research, and it may very much depend on the particular context and the particular health outcome that we are considering, which of these mechanisms is most related. And I want to say also that even though I've listed these as if they are unrelated, in fact, employment and income, of course, influence each other. Income and wealth, of course, influence each other. Social networks and income, these all have causal interrelationships with each other as well. I just couldn't put that many arrows on the slide. It would be overwhelming. Okay, so how do these things that are essentially all social phenomena potentially get under the skin and really influence physical health? Well, of course, one thing that they influence is this actual physical environment that people encounter. So the toxins in your environment, exposure to lead or air pollution, the actual content of exposures and toxins in your workplace environment, whether or not you have access to healthy housing. These are very specific consequences of your financial resources, for example, in your occupation. These things also influence behaviors, and education via knowledge, cognitive skills, and also financial resources influences your behaviors. So behaviors like smoking, behaviors like physical activity and dietary patterns, these are all influenced by both your understanding of what is healthy, your knowledge about what is healthy, the social norms of the people around you, whether or not they consider it totally normal and typical to smoke, or they consider it problematic to smoke. These behaviors are very patterned by socioeconomic position. Infectious diseases, in part because the infectious exposures that you encounter are a function of who the other people around you. And so social networks influence your infectious exposures and also your vulnerability to infections. These factors influence your access to medical care. And I put medical care sort of in the middle of the list because it's one of many, many mechanisms, but access to medical care is clearly an important mechanism by which socioeconomic status influences health. And then there is a set of sort of psychological mechanisms that are really not well understood, but we have very promising evidence that suggests that there are sort of physiologic consequences to experiences of stress, shame, psychological experiences, and that those physiologic consequences actually change your disease risk. So for example, depressive experiences, mental health issues strongly predict subsequent onset of stroke, for example. And we think that this is a real physiological phenomenon, that the psychological experience becomes embedded physically and causes disease. So I want to talk just briefly about why education, among all of the many dimensions of socioeconomic status, so we have lots of possible mechanisms here and several possible indicators of socioeconomic status. Why do I put particular emphasis on education? It's not that the other factors don't all matter. In fact, they often do, and education isn't always the most important. But there are some special things about education that it's important to recognize. For one thing, education influences many other pathways. Because education influences your labor market opportunities and your earnings, education triggers a whole host of pathways. Education is completed early in life, so that although your parents' socioeconomic status may influence your own education, your own adult earnings don't so much influence, for the most part, don't influence your attained education, your completed education. Another point is that education is modifiable on both an individual and a population level. So we can change how much schooling an individual gets, and we know how to increase educational attainment for individuals, and we can and have made tremendous new investments in education at the population level, such that average educational attainment in populations has increased really globally. Education is thought to have few harmful side effects. So in fact, we think that for the most part, there's very little downside of attending school, although there is an opportunity cost to attending school. And education is generally very politically accepted as a target of social policy. It's very often strongly supported, and more supported than direct transfers, economic transfers. That said, why is it important to consider other dimensions? Why not only education? First, education is affected by other resources. So in almost all contexts, wealthy families are better able to provide their children extensive and high-quality education. So even when there's tremendous emphasis on equal access to education, it is very difficult to have truly equal access to equal quality education. In almost all contexts, parents with more resources are able to provide a higher quality or more extensive education for their children. This is in part because the need to work, the opportunity cost of schooling is a major reason that people leave schooling. So people terminate their school because they need to work, because they need to provide their family's income. And of course, if you have a wealthier family, that's less of a concern. And therefore, education may really be a critical link in how health disadvantage is passed from parents to children. So let's talk about the trends in average education. As I said, there have been huge increases in average educational attainment across recent decades in many countries. These are showing, these patterns show net enrollments in primary education from 1990, 2000, and 2011. And so in sub-Saharan Africa, you see that 53%, the net enrollment rate was 53% for primary education in 1990, increasing to 60% in 2000 and 77% in 2011. You could see a similar increasing pattern in Western Asia and Southern Asia. And really, almost throughout the world, there have been big increases. Now, in some places of the world, primary education was already at very high levels, and so primary education did not increase very much. However, if you look at trends, for example, in secondary education, you still see patterns. What this means in terms of when you're actually studying socioeconomic inequalities in older people in particular, is that there is a tremendous age gradient in educational attainment. These are data provided by Ben Capistrant at the University of Minnesota, and these show for Indian males data from the SAGE data by age. So on the x-axis here we have age categories from 30 to 34 years up to 85 plus. And what you can see is that in this youngest group, less than 20% of the population has no education. And then another ballpark 20% has less than high school. Then there's a pretty large group with high school and a non-trivial group with more than high school education. In the oldest group, however, no education is a much more common status. High school, there's still a large population with high school. Very few men have more than high school education in that oldest category. And this pattern is very common, where younger, more recently born cohorts will have more education than older cohorts, and it's graded across the entire age distribution. This is for women, and you can see this phenomenon is perhaps even more extreme for women in this population, where and in the oldest women, very few had any education, and in the youngest women, more than half had at least some formal education. The implication of this is year-to-year increases in the education of school-aged individuals. There are often strong cohorts patterns of educational attainment, such that more recently born cohorts have more education than earlier generations. This means that age and education are very strongly interrelated, and understanding the educational effects requires very carefully adjusting for age and cohort, because age is so strongly associated with health outcomes in and of itself. We'll stop section 1 now. Thank you.